today I'll be presenting on acromioclavicular joint pathologies. So the acromioclavicular joint, sometimes known as the other joint in the shoulder, I'll be focusing on the acromioclavicular injuries, acromioclavicular arthritis, and distal clavicle osteolysis for this presentation. So a little bit about the anatomy. As we all know, the ACJ is a diarthrodial plane joint between the medial facet of the acromion and the distal end of the clavicle. It relies on both static and dynamic stabilizers. So there's a fibrous capsule for the acromioclavicular joint, which encases a fibrocartilage meniscal disc inside. It has a distinct band of superior, posterior, and inferior thickening, which forms the acromioclavicular ligament itself. So this assists with anterior and posterior stabilization of the AC joint. There's the stability for the superior and inferior stability of the joint is due to the coracoclavicular ligaments. The cornoid ligament serves mostly to aid with superior and inferior stability, whilst the trapezoid ligament also assists with resistance of acromioclavicular joint compression. The dynamic stabilizers of the acromioclavicular joint are the anterior part of the deltoid as well as the trapezius muscle. So AC joint injuries occur in 9% of all shoulder injuries. They occur in young people, predominantly from 20 to 40 years of age. There is predominance in males, and they occur as a result of trauma. The acromioclavicular joint relies heavily on its stabilizers, and the spectrum of the injury that occurs is dictated by which ligaments are injured. So injuries can be direct or indirect. So they can occur as a result of a direct fall on the shoulder, or an indirect injury, most commonly occurring during a fall on an adducted and outstretched arm. These injuries are classified using the Rockwood classification, which is a 6-point classification system for the acromioclavicular joint injuries. It's an X-ray based classification using the coracoclavicular distance as a percentage compared to the contralateral side. It infers that the radiographic finding correlates with the severity and the degree of soft tissue involvement for the acromioclavicular injury. So a type 1 is a sprain of the ACJ and the CC ligaments. Sorry, AC ligaments and CC ligaments. Type 2 is a rupture of the AC ligament and a sprain of the CC ligament. So in type 2 injuries, there is some anterior-posterior instability can be examined, but there's no vertical instability. In type 3 fractures, in type 2, the radiographic finding of the CC distance is less than 25% greater than the contralateral side. In type 3 injuries, there is a superior dislocation of the AC joint with a complete rupture of the AC ligament and as well as the CC ligament. And on radio and on plain films, this is seen as anywhere between 25 to 100% of the CC distance compared to the contralateral side. Clinically, the shoulder would likely be depressed due to the rupture of the CC ligaments and then maybe a prominence of the skin overlying the distal clavicle. In type 4 dislocations, there is a posterior dislocation of the clavicle. So there'll be a disruption of the AC ligament, disruption of the CC ligament, there's disruption of the capsule, and as well as a buttonhole of the distal clavicle into the trapezius, which you can see in this diagram here. So this type of injury is not reducible, and as a result will require reduction. In type 5 injuries, there is a gross superior dislocation of the AC joint with ruptured AC ligament, CC ligament, capsule, as well as buttonholing into trapezius as well. And on radiograph, it is demonstrated by a CC distance greater than 100% compared with the contralateral side. There would be marked depression and gross exaggeration of tenting over the skin. And the inferior displacement that as a result of this injury can cause some brachial plexus traction and cause symptoms. This injury is not reducible either. In the type 6 injury of the Rockwood classification, it's an inferior dislocation of the AC joint with a rupture of the AC ligament, the CC ligament, and the joint capsule. These are high injury, high severity injuries and can cause neurovascular compromise. And can be associated with the brachial plexus or vascular injuries. So neurovascular examinations for these injuries are extremely important. So acromioclavicular joint injuries should be suspected if there's a history of pain in the shoulder. Diagnosis can be difficult because of the proximity of the AC joint to other commonly injured shoulder structures. In fact, 18% of high-grade AC joint injuries also have concomitant intra-articular injuries such as slap tears or rotator cuff injuries. On examination, there will be likely tenderness, potentially swelling, and potentially deformity depending on the injury. Attempts for a provocative test can be considered, such as O'Brien's active compression or testing the AP stability on examination, but in the acute setting, the patient may be a bit sore or may be too sore. It's also important to assess for concomitant injuries, especially in those high-grade ACJ injuries and in the setting of trauma. In terms of imaging, it's important to look at the AP and get a glenoid wire view, as well as getting a contralateral AP radiograph of the contralateral shoulder to help calculate the CC distance using the Rockwood's classification. An auxiliary view may be used, and that will assist with looking for posterior dislocation. However, it's hard to interpret and it's actually not easily reproducible. In the setting of trauma, an MRI would often be useful as well to look for concomitant injuries as well. So in terms of treatment options, for Rockwood type 1 and 2 fractures, non-operative management is recommended. There is controversy regarding the best management for type 3 injuries, and consideration of the patient's handiness, their occupation, lifestyles, hobbies, comorbidities, and age should be sought. Most studies support non-operative management for type 3 injuries. However, immobilization period would be longer, up to 4 weeks is recommended. As part of the protocol for patients, they should have analgesia, non-steroidals. They should do passive range of movement once their pain is settled. And then once the sling is off, they can commence active range. They should do scapular exercises, keep their other joints ranging actively, and see physical therapy. So in terms of operative management, the principles of operative management in AC joint injuries depends on the acuity of the injury. In an acute AC joint injury, fixation of the AC joint can be considered with reduction of the joint, allowing the CC ligament to heal and scar, and an AC repair can be performed. In a chronic AC joint injury, the CC ligament healing is not as predictable, and so CC ligament reconstruction should be considered. Weight should also be placed on the type of instability of the AC joint, as an AC repair would help to address an AP instability, whilst a CC reconstruction would help address an inferior-superior instability. Further consideration could be made if the joint requires an open reduction, as then you can do an AC repair at the same time. There are over 60 techniques described for AC joint injuries in the literature. These are broadly split into AC fixation and CC reconstruction. The CC reconstruction can be further split into either anatomic or non-anatomic reconstruction. So an anatomic reconstruction is considered biomechanically superior on both clinical and biomechanical studies, with better strength and stiffness compared with non-anatomic. So in terms of AC fixation, so commonly used fixation method is the AO hook plate to fix this AC joint to mobilize the clavicle and subsequently allow the healing of the coracoclavicular ligament underneath. The benefits of this is it allows for rigid fixation, and the incision also allows a suture repair of the AC ligament. It, however, may require further surgery to take the plate out. It can cause risk of rotator cuff injury, acromial erosion, or pull out of the plate itself. There's been development of button suspensory fixation methods such as the dog bone using suture, and these can be used independently in the acute setting. They can be used in a combined acromioclavicular and coracoclavicular ligament repair and reconstruction in combination with a hook plate, or they can be used as part of an adjunct to a coracoclavicular reconstruction technique such as the modified Weaver-Dunn, which I'll describe a little bit later. The benefits to this technique is it doesn't require removal and there's no issues with migration. However, the fixation itself is not as rigid, may not be as strong, and the technique requires drilling through the coracoid in the vicinity of the muscular cutaneous nerve. So in terms of the coracoclavicular reconstructions, there is non-anatomic, and this is where the Weaver-Dunn or modified Weaver-Dunn is an example of. This is a fixation method between the coracoid and, so the non-anatomic reconstruction is a fixation method between the coracoid and the clavicle, where the fixation is not placed into the footprint of the pre-existing coracoclavicular ligaments, so the conoid and the trapezoid attachments, and thus is biomechanically weaker. Weaver described the technique where the coracoid acromial ligament that attaches from the coracoid and acromion is detached at the acromial end. It is then transposed into the intramedullary canal of the excised distal clavicle. That was the original Weaver-Dunn technique. A modified Weaver-Dunn is when there's an adjunct added to it, so either a suture technique or a suspensory, a button suspensory construct, or even a tendon graft itself. The technique may even incorporate both suture and tendon graft as an augment. This construct has been shown to become lax over time and has a risk of failure though. So due to the biomechanical advantage of anatomic reconstruction of the conoid and trapezoid ligaments, there are multiple variations of this technique published. The Mazzocca technique is a common anatomic reconstruction that seeks to reconstruct the coracoclavicular ligament using a semitendinosus tendon augmented with suture. The conoid tunnel is drilled 45 millimeters from the distal end of the clavicle in the posterior half of the clavicle. And then the trapezoid tunnel is drilled more anteriorly in the center of the clavicle, 15 millimeters laterally. A graft fixation is threaded through the tunnels and either inserted into the base of the coracoid using an interference screw, or it can be looped under the base of the coracoid as a cerclage construct. And the free end can even be used to recreate the AC ligament itself. Other techniques that are described in the literature include this anatomic reconstruction using a triple endo button system to recreate the ligaments with suture. This anatomic reconstruction, which uses the conjoined tendon of the short head of biceps and coracobrachialis to recreate the conoid and trapezoid ligaments. In this technique, described by Nasser, an osteotomy of the coracoid process is performed. The tendon is mobilized superiorly and the lateral biceps bundle is fixed to a previously drilled trapezoid hole in the clavicle, whilst the medial coracobrachialis bundle is fixed to the previously drilled conoid hole in the clavicle, thus anatomic. A tenodesis is then performed of the conjoined tendon back to the osteotomized coracoid using a cannulated screw and washer. So I wanted to discuss these other two pathologies side to side because much of the investigations, treatment and management is quite similar. Acromioclavicular arthritis is a very common pathology. It's asymptomatic in the majority of patients, so the true incidence isn't known. We know that the incidence increases with age. In fact, the fibrocartilage disc in most people starts to degenerate from the second decade, and there is radiologic evidence of osteoarthritis by the fourth decade. There are many reasons for arthritis developing in the acromioclavicular joint. Two of the most common is a primary cause due to just day-to-day repetitive trauma, as well as post-traumatic due to previous dislocation or fracture of the clavicle. So distal clavicle osteolysis is different. It's not a common disease. It's not a disease of aging. In fact, patients are young, they're active, and they often perform repetitive overhead activities such as weightlifting, throwing sports, or even old laborers. There is a preponderance of disease in males, and it's also described disease. It's also a described disease that is found following cranioaclavicular joint fixations, reconstructions, and trauma. The pathophysiology for this disease is thought to be predominantly due to a combination of repetitive trauma resulting in microfractures and fissuring of the cartilage, leading to increased osteoblastic activity. It's also believed that there is a synovial invasion into the subacromial bone, and that leads to the osteolysis itself. The history is similar for both conditions. Pain that is insidious and vague. It may radiate up and down the neck, and the pain is usually relieved with decrease in the activity that's causing it. On examination, they may be tender, they may have swelling and warm, and there may be evidence of other concomitant diseases such as subacromial pathologies. Provocative testing includes a cross-body adduction, which is positive if there is pain in the cranioaclavicular joint when the shoulder is flexed at 90 and then adducted across the body. This is a sensitive test for a cranioaclavicular joint pathology. The O'Brien's test or active compression test is a specific test that is performed by forward flexing the arm to 90 with 10 degrees of adduction. The patient resists downward force of the arm whilst internally rotated, so the thumb is down, and then with the arm externally rotated, so the thumb is up. Pain at the cranioaclavicular joint when the thumb is down and decrease or elimination of that same pain when the thumb is up is a positive test for cranioaclavicular joint pathology, and this is a specific test. The AC, the cranioaclavicular resisted extension test is another provocative test that is performed with the arm and elbow flexed at 90, with the shoulder internally rotated so the forearm is parallel to the floor. Pain on abduction against resistance is a positive test. So in terms of imaging for these patients, plain AP and glenoid Y films should be organized to look at the shoulder. A Zanker view can be obtained, which is a view which is with 10 degrees superior tilt and reduced exposure to help better visualize the cranioaclavicular joint. So this here is a glenohumeral joint, AP for the glenohumeral joint, and this here is the Zanker view, so you get a better visualization of the joint itself. So in osteoarthritis, you would expect to see sclerosis, osteophyte subchondral cysts. You would see joint space narrowing as well, although we know that due to the natural history of the joint disease, that this is probably the least significant finding. In patients with distal clavicle osteolysis, their plain films show relative osteopenia, loss of subchondral bone detail, tapering of distal clavicle, and widening of the joint space. In patients who have a suspected lesion but not detected on plain films, a three-phase technetium bone scan can be used to look for distal clavicle osteolysis. Treatment options for both diseases are similar, and most people respond well to non-operative treatment. A trial of non-operative treatment consists of a protocol of activity modification if they're able. So physical therapy as well, analgesia and non-steroidals, as well as corticosteroid injections, which can be used as both diagnostic and therapeutic purposes. If a patient doesn't respond or doesn't at least have at minimum have a brief relief from a corticosteroid injection, then an alternate diagnosis should be sought, or the injection has not entered the joint itself. So in terms of operative management for these two conditions, the indication to do it is failure of non-operative management, relief from a corticosteroid injection, as well as presence of radiographic findings, and then a consideration for an excision of distal clavicle can be done. This procedure can be performed either open or arthroscopic using a saw or burr. Enough bone should be resected to avoid contact between the acromion and the clavicle. However, over-resection can cause issues as well, as issues described as instability, persistent pain, and even weakness. The literature suggests that a conservative 10 millimeters of resection should be the aim. However, there is a paucity on high-level studies on this subject. So the evidence that I wanted to read about for more clarification in the literature and to find consensus of was to look at the management decision for acute and chronic acromioclavicular joint injury in grade 3 and higher, in Rockwood grade 3 and higher. So for acute injuries, there is a Cochrane review that was updated in 2019 by Marcel Tamayoki, and there's also a systematic review from 2018 by Nicholas Chang that I had a look at. So a summary of the Cochrane review is that it looked at 7 databases and came up with 6 studies. 5 of them were level 2 studies and 1 was a quasi RCT, so a level 2/3, totaling a number of 357 patients. They noted that there was a variety of classifications used between these 5 studies, including degree of displacement, displacement percentage, TOSI classification, and 2 of the studies had Rockwood classification. The outcome measures were considered heterogeneous as well, with follow-up ranging from 1 to 2 years, and outcome scores were a combination of either non-validated scores, there was a use of the constant score, the DASH score, UCLA, simple shoulder test, and Oxford shoulder score as well. The conclusion from the Cochrane study is that there is poor quality evidence in the literature showing that surgery may not be beneficial at 1 year compared with, or may not be more beneficial at 1 year compared with non-operative management. Looking at the meta-analysis by Chang, so that looked at 3 databases. It came up with 19 articles with a total of 954 patients. The injuries were greater than Rockwood classification. Injuries were more severe than Rockwood classification 3, and there was a wide range of techniques used in the operative arms, including techniques that weren't commonly used anymore, such as the Mister technique, the Bosworth technique, and Steinman pin. The conclusion from this meta-analysis is there is no clinical difference at 1 year. Patients in non-operative management group had a more rapid return to work, but overall had last slide anyways. This is the systematic review I did using looking at the chronic high-grade AC joint dislocation that was done here in Melbourne. It's a systematic review using the PRISMA statement, looking at 4 databases. They looked at the AC joint injuries that were greater than 6 weeks post-trauma, was their definition of chronic. Rockwood grade was 3 to 6 with a minimum follow-up period of 12. They looked at 3 groups and lumped them all up to become either non-biologic fixation, so like suture, biologic fixation, so grafts, and ligament or tendon transfers, so more complex transfers such as Weaver Dunn or Dewar type procedures. They included 27 studies. The majority of these studies were level 3 and level 4 studies. 8 of these looked at non-biologics, 10 looked at the grafts, and 14 looked at the transfer procedures. So of the higher level studies, there were only 2 comparative level 2 studies. Tauber looked at 12 free semitendinosis, so biologic versus a modified Weaver Dunn, and they found that the free tendon graft was superior. Fauci looked at 40 allografts, and they compared that with synthetic grafts, and they also found that allografts achieved better scores at the 1 and 4 year mark. There were 3 comparative level 3 studies. Kumar compared modified Weaver Dunn with a Cyrillic, which is a non-biologic, and they found that Cyrillic had higher scores and early return to sports. Kokaglu looked at modified Weaver Dunn versus a palmaris longus autograft, as well as that augment using the graft rope. They found that clinical outcomes and radiologic outcomes were better in the graft group. And then Vitali looked at Dacron and Lars. Sorry, here we go. Yep. Versus conservative management, and they found that Dacron and Lars was better, and Dacron had a higher complication rate. The conclusion from this study is that there was no level 2 studies available. Sorry, the only level 2 studies available show that tendon graft reconstruction was superior, but there is need for more evidence for level 1 and level 2 studies in the literature. Thank you.